from Frontier Nursing University, and this is my SOAP note presentation for NP 702, Fall 2016. The title is Bloody Nose. Subjective data. Chief complaint: my nose has been bleeding periodically on the left side and it's bright red. History of present illness: this 73-year-old white female presents in clinic with complaint of spontaneous, moderate, brisk, bright red, painless nosebleed for the last half hour. Has been experiencing small amounts of painless left-sided nosebleed, mostly in the mornings and lasting a few minutes each time, once or twice a week for the past 4 weeks. Resolved spontaneously after pinching nostrils. Complains of some fullness and mild blockage in the left nose. Denies headaches, loose teeth, or deep ear pain. Denies picking on nose or forceful nose blowing. Currently taking Plavix and ASA for stroke and MI prophylaxis. Denies history of bleeding disorders. Past medical history: MI and CVA 7 months ago. No residual weakness. Denies head or neck tumors, bleeding disorders, hemophilia, or liver disease. Active medical problems: hypertension. Family history: mother alive, dementia, CVA. Father deceased, lung cancer, alcohol abuse. Sibling: 1 brother alive, hypertension, COPD. Maternal grandmother deceased, CVA, breast cancer. Maternal grandfather deceased, diabetes, heart attack. Paternal grandmother and grandfather deceased, unknown history. Surgical history: hysterectomy 1971, tonsillectomy at 15 years of age. No previous nasal or sinus surgery. Social history: drinks 1/2 glass of wine with dinner, denies tobacco or illicit drugs, lives with husband and 2 dogs. Allergies: no known allergies. Medications: Plavix 75 milligrams PO daily times 7 months now. ASA 81 milligrams PO daily times 7 months now. Metoprolol 25 milligrams PO BID times 1 year now. Immunizations: flu October 2016, Pneumovax 2012. Review of systems: HENT denies head trauma, headaches, facial pain, visual problems, sinus pain, nasal insertion of foreign bodies, loss of smell, feeling of blood dripping down throat. Integumentary denies EC bruising. Cardiovascular denies chest pain or pressure, palpitations, dyspnea and exertion, orthopnea, dizziness, fainting, lower extremities edema. Respiratory denies asthma, shortness of breath, wheezing, hemoptysis, cough, lung disease, or history of bronchitis or pneumonia. Gastrointestinal denies nausea, hematemesis, abdominal pain, diarrhea, constipation, indigestion, melena, rectal bleeding, hepatitis, or other liver disease. Genitourinary denies hematuria, vaginal bleeding, or problems. Neuro denies neurological deficits, seizures, ataxia, headaches, dizziness, forgetfulness. Hematology oncology denies cancer or other blood disorders. Objective data: general appearance, vital signs: temp 97.2, pulse 89, respirations 22, BP 140/65, oxygen saturation 97, room air, height 167 centimeters, weight 60 kilograms. Constitutional: well-developed, well-nourished elderly female, appears stated age, in mild stress, alert but slightly agitated, talks in sentences. Physical exam: skin warm, pink, dry, no rashes, pallor, purpura, petechia, or telangiectasias. HENT: head, no facial swelling or deformity. Eyes: no conjunctival hemorrhage. Sinuses: no sinus tenderness. Nose: bright red blood. Left nasal septum: no masses that can be immediately visualized. No septal deviation. Right nose: pink, intact nasal mucosa. Mouth: mucous membranes, gums, tongue, moist, pink, without lesions. Heart: regular rate and rhythm. S1, S2, clear, distinct. No murmurs. No jugular venous distension. No edema. Strong peripheral pulses. Lungs: clear lung sounds in all fields. Full expansion. No chest wall tenderness. Lymphatics: no cervical nodes enlargement. Primary diagnosis is epistaxis anterior bleed. Secondary diagnosis: long-term current use of antithrombotics and antiplatelets. This is the most likely etiology due to history of ASA and Plavix use and the site of bleeding in the Kieselbach plexus and the anterior portion of the nose. Bright red bleeding is arterial, which is more common in the elderly because of mucosal and vascular atrophy. Burrell and Molly, 2014. I acknowledge that there are no other obvious symptoms of GI or GU bleed associated with antiplatelet use, so I will discuss the differential diagnosis later on. Definition: epistaxis is a Latin term derived from the Greek words epi, meaning above, and stasin, meaning to drip. It is one of the most common ENT emergencies to present to primary care practitioners. Yao, 2015. Garg, 2015, defines epistaxis as bleeding from the nostril, nasal cavity, or nasopharynx. It can range from recurrent mild bleed to severe life-threatening emergency. Saran Algamal, 2015. Etiology: local facial trauma or local irritation from picking, forceful nose blowing, neoplasia, upper respiratory infection, chronic sinusitis, exposure to irritants, cocaine abuse, allergies, angiomas, nasal steroid sprays, and septal abnormalities. Systemic causes are granulomatous diseases like Wegener's and sarcoidosis, hereditary hemorrhagic telangiectasia, infection, bleeding diathesis, malignant hypertension. Environmental causes are dry indoor environment and lack of humidification, dry winter months with changes in temperature and humidity, and circadian rhythm, common in the morning and late afternoon. Yao, 2015. Gurol and Molly, 2014. Garg, 2015. Medications include NSAIDs, warfarin, clopidogrel, and factor X inhibitors. Yao, 2015. Idiopathic is, of course, unknown. Pathophysiology: the nasal cavity receives blood from the internal and external carotid systems and is therefore very vascular. Garg, 2015. Disruption of the nasal mucosa by trauma, ulceration, bleeding disorders, inflammation, and neoplasms result in epistaxis. Gurol and Molly, 2014. Risk factors are related to etiology and, of course, include nose picking, coagulopathy, acute or chronic sinus infections, uncontrolled hypertension, liver disease, alcohol abuse, blunt nose trauma, cocaine use, dry and cold climate, septal deformities, granulomatous diseases like Wegener's and sarcoidosis, and long-term use of anticoagulants. Hollier, 2016. Prevalence: about 60% of the population will be affected by epistaxis at some point. Garg, 2015. It is the second most common cause at 33% of all emergency ENT admission this is after sore throat. Barnes, Spielman, and White, 2012. Diamond Plus, 2014. It is common in children 10 years and below and adults above 50 years old. Dynamite Plus, 2014. 90% of nosebleeds occur anteriorly. Garg, 2015. Death from epistaxis is rare. In 2005, there were 7 deaths related to epistaxis, and in the US, all age 75 and older. Barnes, Spielman, and White, 2012. Anterior epistaxis is usually unilateral, continuous, moderate bleeding from a group of blood vessels in the anterior septum called the Kieselbach plexus. Most are venous bacterial sores, becomes common in advancing age due to mucosal and vascular atrophy. It is the most common site for those taking antiplatelet agents. Anterior bleeds account for 90% of epistaxis incidents. Gurol and Molly, 2014. Posterior epistaxis is intermittent brisk arterial bleeding flowing posteriorly into the pharynx. Common in the elderly and those with severe facial trauma. Gurol and Molly, 2014. There could be hemoptysis, nausea, and vomiting from swallowing blood, hematemesis, melena from posterior bleed, or anterior bleed with high blood flow. Yao, 2015. Hollier, 2016. Dynamed Plus, 2014. Differential diagnosis. Because epistaxis is a symptom, Hollier, 2016, the differential diagnoses are based on etiology. First is the presence of a tumor that could be out of sight during inspection. A tumor cannot be ruled out considering the unilateral nature of the bleeding, Blomgren, 2014. The patients complained of some fullness and mild blockage in the left nose, even without the other symptoms of headache, loose teeth, or deep ear pain could be suspicious for a tumor. Yao, 2015. Idiopathic epistaxis is another differential because it represents a majority of the cases. Yao, 2015. And because of the apparent source of bleeding in the left nasal septum anteriorly. Gurol and Molly, 2014. I did not consider ruptured carotid artery aneurysm or traumatic carotid cavernous fistula, as these are severe forms of bleeding that will not present in primary care. Immediate treatment. Adult epistaxis management. Step 1 is protect airway and assess cardiovascular status. Assess for signs of compromise from fluid volume loss. Advise patient to sit and lean forward so blood does not run down the posterior pharynx. And have the emesis basin ready to catch any bleeding. Have patient pinch nostrils, not the bony bridge of the nose. Apply direct pressure to the ear for 10 to 15 minutes. Step 2 is topical vasoconstriction with oxymetazoline spray or soak using a cotton ball with oxymetazoline or phenylephrine and press against the bleeding site for 10 to 15 minutes. This facilitates identification of the bleeding site so step 3 can begin, which is cautery of the bleeding site. It is done chemically with silver nitrate or electro cautery, which is usually done in the ER or the hospital. Procoagulant dressings such as calcium sodium alginate could be used for anti-platelet therapy patients as an alternative to cautery. Step 4 is nasal packing when cautery fails. Maricel is one commercial product used for packing. Dynamed Plus 2014. Barnes, Spielman, and White 2012. If anterior packing fails, posterior bleeding is suspected and posterior packing will be needed. This is more complicated and is usually done by an ENT or in the hospital. Medications. In the clinic, vasoconstriction with topical oxymetazoline is first-line treatment. Topical neosynephrine may also be used as well as 4% lidocaine. Gurol Molly 2014. Silver nitrate applicators may be used once site is identified. Care should be taken during bilateral cautery, which can lead to septal perforation. Yao 2015. An alternative for patients on antiplatelets is the use of calcium sodium alginate, which is a procoagulant dressing. Dynamed Plus 2014. Diagnostics, Gurol and Molly 2014 state that lab studies are ordered on the basis of findings from the history and physical exam. Usually no lab test will be ordered for epistaxis that is not severe, but the history of Plavix and ASA will warrant checking the hemoglobin and platelet counts all year 2016. Side effects of oxymetazoline for minor side effects are burning, dryness, stinging inside the nose, sneezing, and rhinorrhea. But have the patient report immediately to the prescriber if there is angina, tachycardia, passing out, severe headache, or severe nasal irritation. Signs of significant reactions are wheezing, chest tightness, fever, itching, bad cough, blue skin color, seizures, or swelling of the face, lips, tongue, or throat, which should be reported right away or patient sent to the hospital. Lexicomp 2016. Care should be taken when using silver nitrate applicators for patients with history of nasal surgery or those taking antiplatelet agents for increased risk of further bleeding and septal perforation. Gurol and Molly 2014, Yao 2016. Patient education, avoid trauma to the mucosa, avoid picking, excessive rubbing, or forceful blowing. Keep septum well coated with vitamin A and D, ointment, petrolatum-based zinc oxide, or OTC bacitracin ointment until the site is healed. Teach home remedy for minor recurrence of bleeding by first spraying afrin nasal spray to the bleeding area, then packing the site with cotton gadgets soaked in afrin spray and apply it for 10 minutes. Consider use of OTC nasal Cs, another calcium alginate product. Explain importance of humidifying the home, partially opening a few windows, placing water in containers near radiators or stoves, and obtaining a humidifier. Consider stool softeners to prevent bearing down that increases risk of nosebleed. Gurol and Molly 2014. Consult or refer for possible tumor to ENT, for recurrent bleeding despite treatment, to hematologist, or to the hospital for severe bleeding. Bleeding that's stopped by tamponade could be posterior bleeding and needs to be sent to hospital right away. Dynamed Plus 2014, Gurol and Molly 2014, Yao 2015. Follow-up, call the clinic if home treatment fails. Make follow-up with the patient within 24 to 48 hours after nasal packing for anterior epistaxis. Or an earlier follow-up is recommended if there is bleeding, fever, drainage, or increased pain. You may consider leaving the pack for 48 hours if the patient is on anticoagulation or if there is a high risk for cardiac or hemoglobin of less than 9. Remove all packing for posterior epistaxis within 48 to 70 hours to prevent tissue necrosis and infection. Health promotion. Avoid alcohol. Patients with epistaxis were likely to have consumed alcohol within 24 to 48 hours of presenting to the clinic or hospital. Alcohol and clopidogrel don't go together. Manage hypertension to prevent malignant hypertension, which may predispose to epistaxis, although there is weak evidence in the relationship between hypertension and epistaxis. Prevent upper respiratory infection. Lubricate the nares often, humidify at night and in winter time, and stop smoking because it dries the nasal passages. Yao 2015, Hollier 2016, Sarhan and Algamal 2015. The treatment guideline for epistaxis from the American Academy of Physicians is 11 years old, hence it was not referenced here. The Dundee epistaxis protocol has 5 steps, and this is the same as the intermediate treatment that was discussed earlier. So step 1 is assessment and resuscitation, includes airway protection, sitting up, leaning forward, clearing the nose of blood, and assessing for cardiovascular status for signs of fluid volume loss or shock. Step 2 is application of topical vasoconstrictors like oxymetazoline, phenylephrine, tranexamic acid, or lidocaine anesthetic. Anterior compression is done with a cotton ball soaked in the vasoconstrictor or anesthetic, and this facilitates identification of the bleeding site. Step 3, once bleeding site is identified, chemical cautery with silver nitrate or electrocautery is performed. Silver nitrate may be applied in the clinic. Used with caution in the elderly and those on antiplatelet therapy. Procoagulant therapy with calcium sodium alginate would be better alternative for patients with epistaxis from antiplatelet medications. Nasal packing is step 4 and done when cautery is not effective. Anterior packing may be done in the clinic, but posterior packing is best done by an ENT or in the ER. When anterior packing does not stop the bleeding, a posterior bleed should be suspected. Vascular intervention is step 5 with embolization, and it is done in the hospital. Barnes, Spielman, and White, 2012. Pharmacologic treatment, Afrin or oxymetazoline 0.05 nasal spray is first line. Spray twice into each nostril. Have patient pinch his nostrils tightly for 10 to 15 minutes. Oxymetazoline spray is as sole therapy has been reported to resolve epistaxis in 65% of patients. Study. Gelatin, thrombin, hemostatic matrix sealant, or flow seal is reported to resolve bleeding in most patients and appears to be more effective than nasal packing. Tranexamic acid soaked pledget may resolve bleeding and reduce risk for rebleed more effectively than anterior packing with epinephrine and lidocaine soaked pledget in patients with idiopathic anterior epistaxis. Procoagulant therapy like calcium sodium alginate nasal packing for patients at anticoagulation or antiplatelet therapy may be more effective and preferred over local treatments such as cautery. Dynamed Plus 2014. Silver nitrate 95% should be used with caution in the elderly or those with epistaxis resulting from antiplatelet therapy. These patients have friable blood vessels. Kurol and Molly 2014. Diet. Avoid hot foods which can trigger nosebleed. Yao 2015. Activity, strenuous activity, bending, straining, nose blowing, all put the patient at risk for recurring nosebleed. Dynamed Plus 2014, Yao 2015. These are my prescriptions for Afrin nasal spray and for bacitracin ointment and diagnostic tests as CBC. These are my references. And thank you for watching.